Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to this edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. And our goal is to spark conversation, ideas, and action. Since we are live, I want to remind everyone about how to ask questions of the presenters. Since the audience lines are muted, we don't take questions over the line. However, you all have the opportunity to type your questions into the question box at any time. I will check for the questions at the end of the session. But please don't feel you need to wait until then before posing your questions. Just type them in the question box as you think of them. We are delighted to welcome today Children's Healthcare Canada member Alberta Children's Hospital to bring you KidSIM Mobile Outreach Education Program. For those of you on Twitter, please tag us at ChildHealthCan for any webinar-related tweets and share away. I'd like to introduce our speakers. Dr. Kim Landry is the Assistant Medical Director for KidSIM and the lead for Mobile Outreach Education Program. And Jenny Chatfield is an emergency department nurse at Alberta Children's Hospital and a simulation education consultant for KidSIM. It's my pleasure to pass the mic to Kerri.
Good morning, everyone. Jenny and I are really excited and happy to be here to showcase a program that is near and dear to our hearts. So as Paula mentioned, today we're just going to give you an overview on our KidSIM Mobile Outreach Education Program. So to start the presentation, we'll let you know sort of who we are and where we come from. We will give you an overview of our program, the ins and outs and how we built it. We'll give you an insight into some recent projects that we've been working on. And then we'd like to share with you some of the things that we've learned along the way, such as barriers to implementation and some of the lessons that we've learned, sometimes the hard way, as well as the future directions that we may be taking the program in. This is really a talk about our experience. It's not really a how-to sort of, this is what you do to replicate it, but hopefully you'll be able to, if you're interested in outreach, garner some insight in and some lessons from that we've learned along the way. We have no financial disclosures or conflicts of interest to discuss. So who are we? So KidSIM is a pediatric simulation program run out of the Alberta Children's Hospital in Calgary, Alberta. It was established in 2005, and we actually obtained Royal College Simulation Accreditation in 2017. And the thing with accreditation is that it makes all of our simulation activities eligible for credits within the Maintenance of Certification program. And it was a voluntary process, but accredited institutions are often internationally recognized as leaders in simulation-based learning, so we were happy to join that group. And now for years, we've worked out of spare offices and conference rooms, but in 2014, our state-of-the-art simulation center was actually opened. And I'll just give you a little peek into that. So through various fundraising endeavors, our $2.4 million KidSIM Simulation Center opened in January of 2014. And so the KidSIM Center is a 3,600 square foot facility and is the largest pediatric simulation center in Canada. So the center is housed on the 4th floor of the Alberta Children's Hospital, and it accommodates 4 simulation suites, with individual control rooms and 2 proper debriefing rooms. We have a dedicated storage room and then space for administrative and program staff. And we do know that we are so lucky to have such an amazing space. Just a couple of the pictures we've put up here for you today. The bunny picture is a picture of our entrance and waiting room. And then the numbers 3 and 4 just show how we enter into our simulation labs. On the upper right corner is one of our debriefing rooms. And then on the bottom left corner, this is a picture of a beautiful mural and a hallway. And behind each of those panels, we have iPads that allows participants to provide feedback and do evaluations after they've completed their sessions. And finally, in the bottom right is a picture of one of our simulation labs. This is a pic of 2 of our simulation labs, and actually it's just made into one wide open space, but there is a drop-down door in between, so you can separate them and make them into one larger space if need be. Now, all of our labs are set up in the same way with medications and airway carts, adjuncts, like intravenous's, intraosseous, C-collars. There's TV screens that can project the labs and x-rays. And there's also control rooms behind the 2-way mirrored glass so that facilitators can observe and also control the room from behind that. So again, we do know that we're quite lucky to have such a great space to work in. One last little overview of our KidSIM program before we move on specifically to mobile outreach, but this is data from for KidSIM from 2018 and 2019. And it just shows that we're quite a large program. In 2018-2019, we did 631 sessions and taught over 6,174 learners. And the other thing I want to highlight is at KidSIM, we really believe in interprofessional education. And so 57% of the sessions that we put on were interprofessional, meaning involving one or more than one profession, such as nursing, physicians, EMS, pharmacy, RTs, you name it. We really like to get teams working together from the ground up. These are just, again, another snapshot of our programs that we do. You can see that a lot of energy is focused on the emergency department. We do a lot of sessions for the emergency department, where that be residents, fellows, and staff level continuing education, sorry. But we also work with our transport team, our inpatient units, family-centered care. We have a robust research team that does some simulations in the center, and as well as the OR and NICU and PICU. Obviously, though, the program that is nearest and dearest to our hearts, and the one that we're going to talk to you today about, is our mobile education program. And so in 2018-2019, we did 22 sessions, but for the 2019 year, we actually upped that to 29 sessions. So I'm going to pass the mic over to Jenny Chatfield right now, who's going to talk to you a little bit more about our mobile ed program.
Good morning, everybody. So I'm just going to take some time and we're going to talk about the mobile education program that we have here at the Alberta Children's Hospital with KidSIM. So why do we do mobile education? We know that the majority of children in Canada are not seen at tertiary care pediatric centers. A lot of doctors and nurses are uncomfortable with seeing pediatric patients and respiratory therapists. They have very few opportunities to see sick kids and a few opportunities to practice after their training is done. Simulation allows them to practice these high-risk, low-frequency events. By bringing it to them, it allows them to practice in their space with their own team members. They can identify latent safety threats, and we can provide resources and share tips on how to organize their pediatric equipment or possibly their room. It allows us to see their reality and understand that they often practice with limited resources. So we started mobile education back in 2008, but we have grown considerably since then. You can see on the slide that these are the latest numbers for our team. So in 2018, we went out to 29 mobile sites. We had 29 visits, and the places that we went to were from Edmonton down to the border of Canada and the United States on Alberta. And those sites could include such places as Medicine Hat, Red Deer, just below Edmonton. And the people that attended these events were attending physicians, medical students, nurse practitioners, nurses, RTs, LPNs, and sometimes EMS also joined the sessions as well. So our mobile ed team is myself and Dr. Kerri Landry, who's the medical lead. And we are the people who do a lot of behind the scenes stuff. So such things that we would do is curriculum development for the year, planning and scheduling of sessions that we go out to. Over the years, we have created introductory emails and reminder emails to send out to our sites when booking the trips. We have also sign-up sheets and lists of materials that the sites may need for the sessions. We also do a lot of real-time problem solving from a distance sometimes, and also after the sessions have done. And we don't go on every trip for our mobile ed, as there can be between 22 and 30 trips a year. So we send out a team to go out. So what does our team look like? So we have a team leader. If the site expects a lot of learners, it is possible that we add to the team. The reverse is also true. The minimum we would be for the team would be, however, 3 people. So the team leader is usually an RN or an RT. And the reason that we've chosen an RN or an RT, it's just because of the contracts that the RNs and the RTs have a different contract with Alberta Health Services than the physicians do. So the responsibility of the team leader is for driving the van to and from the site, coordinating the meeting time for the session, ensuring all things are loaded into the van, and also to complete a safety checklist. We have created a document of the team lead's responsibility, which helps as a memory aid for the trip. The team lead is usually an RN, but it can also be an RT. MDs are not employees of AHS, so it's harder to get them licensed to drive AHS vehicles. So MDs, RNs, and RTs are all members, and they have all been asset trained. So they've all taken our simulation curriculum of courses, and they've all been trained on debriefing and simulation. And we have a checklist of team members that are members that have responsibilities. So what does our mobile education equipment look like? As you can see in this picture right here, we do have a GOMARD mannequin on the stretcher, and the GOMARD mannequin does have capabilities of being wireless, so that's very handy when we're taking them out to the site. The mobile edge stretcher has been custom built so that we can load it on and off the van. And you can see that there are 2 drawers below the stretcher. And in those 2 drawers are all the supplies that we would need for teaching for the sessions. So what does our mobile equipment look like? So we have a mobile van, and as you can see in this photo right here, there was a custom built ramp that loads 2 stretchers into the van. So we can accommodate about 2 stretchers, and the maximum amount of people that we can accommodate to sit comfortably into the van is about 5 to 6 staff members. And you can also see in that van that we're pretty lucky in that we've got some extra storage. Some of the drawers do pull out, so we can put some extra equipment. So we're really feeling very fortunate to have such a vehicle to lug our equipment to and from sites. So the agendas for a typical session. So a typical session usually lasts for about 4 hours, but the start times are flexible and depend on travel time. So it's very site specific. So as you can see on here, usually we break it down into hourly intervals, and the first hour is usually spent time talking, and then we usually have another hour for a quick snapper, and then we'll usually run about 2 more cases, and then we'll take a break, and if the site would like another session, then we'll go through another session. So sometimes, depending on the distance, we travel in the morning and do a session at one site in the afternoon, stay overnight, and drive to another destination the next day. At larger sites, we may do a session for the emergency department and then their pediatric unit on the next day. All depends on the size of the site and the geography of where the site's located. So what's included in the first hour? So the first hour is a time for us to sit down and talk with the team and put out our feelers to see how they're doing, and an opportunity for us to talk with them and to answer questions that we might have. It's also an opportunity for us to do introductions, explain expectations for the day prior to the sim experience. It's also a good time to ask their nurse educator about any recent pediatric cases, so as to avoid surprises and not end up doing a debriefing of traumatic events. Over the years, we have trialed other things for the first hour. So such things we've tried as teamwork training and crisis resource management, workshops on pain, and the management of diabetes, ketoacidosis. If you're just starting, one of the best things we've found is using a simple case to take the team through all the basic elements that they will need during the simulations. For example, setting them up for success. So what does it mean to setting them up for success? It means in this slide, you can see that there's lots of topics that you can choose to talk about in the first hour, such as sectioning, oxygen delivery, bolusing, and just reviewing those skills so that they can feel successful during the simulation session when they're practicing these skills. So what does the curriculum look like? So our curriculum changes every year, but what our curriculum our curriculum, we have a set curriculum for 4 years, but every year we change up the cases. So the we start with a quick snapper. This is a quick case of a topic that the participant should be familiar with, and it's not too complicated. It gives them an opportunity to shake off their nerves. Then we will do a long medical case and a long trauma case. Some of the themes that we usually have include a baby, as people really like to practice for these because they feel quite nervous about neonates and managing neonates. We build cases that involve having a weight, using the Braslow, correcting the glucose, treating pain, giving fluids, IV access, and also calling for transport. After a needs assessment a few years ago, we have made tweaks to this curriculum to address some of the specific concerns that the sites do have. And as our program has evolved, we've included telemedicine. So we've started to integrate telemedicine into our simulation sessions. We've identified sites that already have existing telemedicine equipment from a stroke program in the province. And during the simulations, when the sites need to call for help, they use telemedicine. They are able to call to our transport team, which is located here at the Alberta Children's Hospital. The team assembles and watches the sim remotely and provides guidance during the resuscitation and plans for transport as they would in real life. So far, the feedback has been really great about this program and the use of telemedicine. So I'll hand the mic over to Kerri.
Well, thanks, Jenny. The last thing about our specific mobile ed program before we move on to recent projects that I just wanted to touch on is funding. When we go to different conferences on simulation and people are interested in our program, they often ask about funding because it's definitely one of the rate limiting steps or the barriers. It is complicated to fund a program like ours, and there is really no set recipe. So ours is a bit of a jigsaw puzzle with funding from various pieces that come from different places. And so some revenue generation by the use of our simulation center, definitely rely on a lot of philanthropy. We rely on funding from the Provincial Health Authority for specific simulation positions and consultants, as well as some funding for the university. And so I wish I had a recipe for funding, but that's what our makeup looks like. So I'd just like to move on to some recent projects that we've been working on. So after a while from running the mobile simulation program as is, we started to ask ourselves whether or not we were meeting our participants' needs, if what we were doing was helpful, and if there was a way that we could improve care. Because for years we ran our educational sessions and we did do evaluations, but we didn't have any concrete data to show for it or any kind of feedback for us to make us better. So we thought the best place to start was to do a needs assessment. So we wanted to know what our sites thought about the program. We wanted to see how we could improve and we wanted to understand what their challenges were. And so it was actually really hard to find out who works where. So we knew the nursing educators, but with staffing changes of small hospitals, it's hard to sort of find out who was in charge. And so it took some cold calling when we did this needs assessment. But we eventually did update our contact list and embarked on this needs assessment. So we did send out the survey to our 32 mobile education sites who were geographically linked with us. And I'm happy to say we've actually since added a few more hospitals to the list, so we've grown our relationships. We sent the survey to the nurse educator or manager and the physician who oversaw the emerge. And as you see here, one thing we did learn was that you should never do a survey in the summer. It just was temporarily related to when Jenny and I started in our positions, but we did send the survey out for the summer. So that was a hard time to collect data because people are often on vacation during that time. But we did have a 40% response rate, and the majority of the respondents were nurses. We did have some physicians, and about 85% of them had participated in our mobile ed program before. So I won't take you through the whole survey now, but here's a few of the questions that we thought reflected our findings. So what did our participants like about mobile simulation? They really liked practicing in their own center. They highlighted several times about the interprofessional nature of the session, and this went two ways. They enjoyed that they got to participate themselves as an interprofessional team, but they really enjoyed the fact that our facilitators came from different disciplines because they felt that that reflected their own voices during the simulation. They highlighted that it was important for them that we had non-judgmental supportive facilitators. They enjoyed having dedicated time with pediatric experts. They really enjoyed focusing on hands-on practice. And they liked that we were able to come to their site and see for ourselves and understand their local resource limitations. Many of them asked us not to stop coming, so we felt pretty good about that. What did they want to change about simulation? And so one of the things is about local staffing issues, and that just highlights how hard it is for people to get time off to do these sessions. And so it's often really hard for in small centers for nurses to pull people off the floor to come and work or come and participate in one of our simulation sessions. They did highlight that they like to always have a ND facilitator as part of the teaching team, and they were hoping that through our relationship that we could help them advocate for better pediatric resources in rural communities. What are the barriers to participation? So how do our participants feel, or what is it that prevents them from participating? So one of the higher ranked list items was anxiety about participating, and I feel like that's completely understandable. I know I participate in our staff level simulations, and I too get nervous before going to them. No one wants to feel silly in front of their colleagues. The other barrier at that time was obtaining CME credits, that they felt that if they were coming to these sessions, they wanted to be able to get credit for them. And we have rectified that with getting our accreditation. And the other barrier was about communication on dates and times. They felt that they didn't have enough leeway to organize their schedules. When we asked them what types of cases they would like, this was their responses. So they wanted a mix of high yield common cases as well as a few high impact rare cases. They wanted to continue the combination of didactic and hands-on simulation. And some of the specific topics they listed were intubation and airway, trauma, sepsis, some respiratory conditions, as well as DK and burns, most of which were in our current curriculum, but if they weren't, we found ways to add that to the cases. And we did ask them at the end what the greatest challenge for rural pediatric care was. And again, they highlighted the general anxiety about the care of children. And they felt that they had the lack of skill and experience and knowledge to deal with everything that they felt might come through their doors. They felt team communication was another of the challenges, as well as, just knowing about pediatric medication dosing and IV starts and what resources were available to them and the transport issues. So after our needs assessment, we felt that it was really important to continue with the program, and we did make tweaks to ensure that we were communicating better with our sites and that we were tailoring our cases to their specific needs. So after the needs assessment and that tweaking of our curriculum, our next project was developed to try and determine how ready our sites were to receive pediatric patients. So we asked ourselves the question, did they have the bare minimum they needed to care for kids? So just to give you a little bit of background, as we mentioned earlier, a large proportion of emergency visits for pediatric patients across Canada are to general emergency departments. And we know from the literature that general emergency departments do lack the resources and personnel to effectively care for children. So there's an old study from 2001 that surveyed all the emergency departments across Canada, and they did find that essential pediatric resuscitation equipment was unavailable in a high number of centers. And the US has similar data. Although we have no current Canadian guidelines for what's recommended to staff in terms of equipment and policies, the US does have guidelines, and we have found that they are applicable to us. So we came up with a QI project with one of our pediatric emergency medicine fellows that was just published in the Journal of Pediatrics and Child Health. And we had asked ourselves the question, if our sites wanted to get better, did they have the necessary resources to deal? And I'll just let you into something, share with you a little bit. We've never given formal feedback back to our sites before. We would obviously go on trips and debrief, but we didn't have a system to provide formal feedback. And it was something we worried about because we didn't want sites to feel dejected and not want to participate if we gave them formal feedback on their performance. So we felt starting with equipment and some policies was a good place to start, as it was more on how sites were organized and nothing to do with their actual performance. And then just another aside is that we were initially going to survey only our sites, but we did decide eventually to include the whole province since we were doing the work anyways. And so we did a provincial assessment of the readiness for pediatric emergencies. What were the resource gaps in Alberta? So as mentioned earlier, the US does have a pediatric readiness score that existed in the literature, and it was reviewed and found to be applicable to Canadian emergency departments. So we sent out another survey to 107 general emergency departments and urgent cares in Alberta, Canada. Now, this pediatric readiness score is a 55 question score, but then gets normalized onto a 100-point score, and it addresses 6 categories. So the coordination of patient care at a site, is there a physician, nurse, or both in charge of pediatric care? Whether or not they have a physician and nurse staffing and training guidelines, as in what level of training is required to work at the institution, and do they have competency evaluations for their staff? What quality improvement initiatives exist at the sites? Is there a pediatric patient care review process? What patient safety initiatives exist at the sites? Are patients weighed in kilograms? Do they use pre-calculated drug dosing? We look at their policies and procedures, and then what equipment and supplies do they have? And there is a list of standardized equipment. So this is the results for our study. So we did the readiness for pediatric emergencies in Alberta, and we did have a 60% response rate. So for our study, the median weighted pediatric readiness score was 48.4 on 100. And what does that mean? So it is considered to be low compared to the most recent US study in 2013, where their median weighted pediatric readiness score was 68. However, the US study was completed after the institution of a national initiative aimed at improving pediatric readiness, which obviously has contributed to their higher scores. But regardless of our result, it did indicate that there is some room for improvement. And so what we did was all sites that participated in our study received an individualized scorecard highlighting their areas for improvement. And that allowed them to have something concrete for the nurse educators and the physicians to work on and to close some of the gaps in their pediatric readiness score. Of note, we did find factors that were associated with higher degrees of readiness were high pediatric volume. So sites that saw more kids, which makes sense, had a higher pediatric readiness score. And the other thing that was found to be associated was an involvement in a simulation outreach program. So this showed that by going to the sites and helping them and going through some of the way they organize their equipment, that it did lead to a higher pediatric readiness score. So one of the last projects that I wanted to talk to you about that we've been working on is something called the IMPACTS collaboration. So IMPACTS is Improving Pediatric Acute Care Through Simulation, and it is actually a collaborative in the United States based out of Yale University. And so their vision really spoke to Jenny and I, because their vision is to ensure that every ill and injured child receives timely and safe, effective emergency care whenever and wherever it is needed. And so again, going back to the fact that the majority of children are seen at non-tertiary care centers, we felt that this was a group that aligned with our vision that we could work with. So IMPACT specifically is an innovative improvement intervention that involves pediatric children's hospitals becoming hubs, so centers of excellence, collaborating with community spokes, so lower volume emergency departments. The team then gets supported by the Central Core at Yale University. So we became a hub hospital about 2 years ago and embarked on a quality improvement project with them, which I'll take you through. So this QI project that we embarked on with the IMPACTS group aimed to see if community emergency departments, when partnered with a hub hospital, could see an increase in their pediatric readiness score. So it used the same score that we had used in our prior QI project. We recruited 2 spoke hospitals specifically to partner with us. The spoke hospitals agreed to have us come and measure their pediatric readiness score, as well as do 4 simulations during which we would actually score them. And so this again was a little bit of a leap for us, because prior to this, we had not wanted to give feedback on participants' performance because we didn't want to scare them away from participating. But because of the other projects we'd done with them and the relationship we built, we felt that this was safe to do this time. So intervention was considered time 0. And 2 weeks later, we would provide them feedback on all the data that we had collected. And then together we would choose action items for them to work on. And then we followed up with them at 2 months, 4 months, and supported them if they were having trouble sort of working on their action items, if they needed any more resources from us. And then at the end of the intervention at 6 months, we did remeasure their pediatric readiness score. The aim of the study was to see if we could increase the pediatric readiness score at participating centers by about 15 points. So I want to just give you now an example of the feedback that the sites got, because it's quite detailed. So this is just a snapshot. This is a fake hospital. We'll call it the Smith Hospital. So after a site participated in our simulations on the day, at the 2-week mark, we fed them back this information. And this just shows sort of how they performed in terms of their pediatric readiness score. And they also got to see how they performed compared to a similar general emergency department, as well as a sort of the gold standard, which would be a pediatric emergency department. They got to see their scores on the 4 cases. So they did a foreign body case, they did a sepsis case, they did a seizure case, and they also got a teamwork score, so how they performed. And this allowed them to sort of see and get a snapshot of where they were in relation to others. In addition to this, we did give them the breakdown of their pediatric readiness score. So how did they perform on those things I'd mentioned earlier? How did they perform in terms of their quality improvement, policies and procedures, patient safety, physician and nurse staffing and equipment? And again, in relation to how the other groups did. And then I think the most important feedback that they did get was just in terms of selecting action items. So we worked with our 2 sites on selecting action items that they felt that they could readily improve on over the next 6 months. And we did support them with resources. So this project is actually still ongoing. As I mentioned earlier, the aim is to improve the pediatric readiness score by 15 points. And at the end of this, at the completion of this project, Jenny and I will sort of explore whether or not this is feasible to roll out to all of our sites. We really just tested this intervention for 2 of our sites, but the feedback so far has been excellent. So now I'm going to pass the mic back to Jenny, who's going to talk to us a little bit about the barriers to implementation and some of the lessons that we've learned.
Thanks, Kerri. So we're going to spend a little bit of time talking about some of the barriers and some of the things that we've learned from implementing this program over about 12 years. So one of the things that Kerri and I are so grateful for is to have funding for this program. We know that that's often a challenge that all programs have, but one of the challenges that we do have is cost associated with running a program like this. As you can imagine, we pay our staff for their time going out to the site and the time that they're at the site. So we do pay them for their travel to and from. And as you can see, if you were to have about 6 staff, including nurses, RTs, and physicians, it can add up over time. Another challenge that we do have is distance. So Alberta is quite a big province, and sometimes distance can be a challenge, especially in the middle of the winter and with the roads being quite bad for travel. We don't do any traveling over the summer just because a lot of the sites, the staff are on holidays, and it's hard to recruit during that time. Some of the challenges that we do have are with technology. As we all know that with simulation, some things that can be challenging are the operating the mannequins and getting the mannequins and the technology piece up and running. And also some of the things that Kerri and I deal with are managing the breakdown of the van. So sometimes the van has been broken down at sites and we just need to problem solve how to get that back here. Also, having the right staffing mix can sometimes be a challenge, just depending on people's availability. And also the overnight trips seem to be a little bit of a challenge to get staff to stay overnight. Some of the lessons that we've learned over the 12 years that we've been running the program is when we look back to reflect on the lessons we've learned along the way. If any of you are considering starting a program, hopefully these tips will help you. So we need to build relationships with the rural centers. So find out what they want, develop an introduction letter to open the door for communication. Go first where you're wanted, get your feet wet, build momentum, and word of mouth travels quite quickly. So get to know your learners. Do a needs assessment, a survey, a focus group of your learners. Get to know what they really want. Don't assume what they know and what they need and what their expectations are. Design realistic scenarios. So consider who normally does these resuscitations. And if they usually have only 1 or 2 nurses and a doctor, then it won't be realistic for them to run a session with 6 people. So think about the people that you need at the table for the sim session and what is realistic for them at the time and when it's appropriate to call for help. Be organized. So you will need to be organized. So you will forget stuff, and that's okay. Be really, really flexible. Flexible with the start time, flexible with the staff that show up, flexible with where the simulation scenario goes, flexible with your debrief, and flexible with your schedule. Make a list of things that you'll need to take out to the site. Create bins so that you can have all of your equipment ready to go. Restock them when you come back. Safety is very important. So one of the things that we do is all of our medications that we take to the site, we put blue dye into it, and we label a little bit differently than what you would see in the real world so that it's easy to pick up and identify that this is not a real medication if it was, heaven forbid, left behind on site. Identify all of your simulation equipment, so label it appropriately so that it's easy to identify that it's a simulation equipment. Don't take any of their equipment, and make sure to restock after you leave, restocking their equipment. So this picture right here, so be as portable as possible, is from the early days. So back in the early days, we put everything into our vehicles and drove out to the sites. So you can see that we grabbed a mannequin and all the supplies that you needed and put it into the vehicles and off we went. Right now we're feeling really lucky and very fortunate to have this mobile ed van that we've talked about before. And what it really allows for us as a team to do is to be flexible. And it really provides an opportunity for our team to have an hour or two on the drive up to come together as a team and talk about what their plan is for the day, and also to help build relationships. So it's really nice that we can have the whole team together and all of the equipment together and travel together. In this photo right here, it also shows other ideas for other departments that have chosen to use different ways of being portable. So using an RV is also another way that you can have your simulation portable center within an RV. So that's also another idea. You just don't have to have a van and to unload and load your equipment. So recruiter team, this is one of the most important things. Remember, they are the face of your program. They need to be respectful and understanding. If they aren't, the participants will not want you to come back. So we've been really fortunate and that we have such great staff here that work with us. And we're really, really fortunate and grateful that our staff are very flexible, they're respectful, very understanding of the learners and the people at the site. They're quite humble and they don't go off onto their soapboxes when out teaching with the other sites. Oftentimes, as a facilitator, you do need to take a few moments and you might need to swallow your pride. So commenting on comments about doctors are often shy to come by, but don't want to look stupid in front of their peers. So oftentimes you just need to swallow a little bit of your pride and ask a few more questions to really engage the learners and to get them to participate in the debrief and really take the opportunity to not make anybody feel like their questions aren't important. So as we said before, be flexible. So you might not have access to the trauma room, and that's okay. You might need to adjust your start times or your finish times, and you need to be able to fly by the seat of your pants a bit as you go along the day. So just being grateful for having the learners and having the space and having the opportunity and just being flexible along the way is really important. So free CME credits for doctors act as a carrot for our physician participants, and we are so grateful that we can offer that. And for the nursing and the respiratory staff and anybody else who joins us, such as EMS, we give a certificate at the end of the session, and they can submit these for continuing professional development. So the weather doesn't always cooperate with us. So here in Alberta, it can be quite unpredictable. We only plan trips from September to December, as I said before, and April to June. So we don't do the summer as recruitment is difficult because of vacation, and we usually don't do January and February because often the weather is quite bad. So we usually end up canceling a lot of our trips. So it makes a tight window for us to get out and to visit the sites. But the less trip cancellations, the better. So we just try and kind of work with the weather as to what works best for the sites and for the weather. So I'm going to hand the mic back over to Kerri.
Great. One of the last lessons that we've learned running the mobile sim program is about community engagement. And engaging your community really does, again, help get the word out about the type of education that you're wanting to do. One of the programs that we participated in is Doors Open YYC. And that's where on a set day in September, Calgary opens the doors to a lot of different things that you don't get to see that the background on. So we open the doors to our simulation lab to the community, and the community comes together to sort of see what we do. We run mock codes and mock simulations. We let them get their hands on. We do CPR challenges. And we found that this has just been a great way to gain community awareness, and it has definitely led to donor support. So that's another thing I'd encourage you if you're trying to get a program out and running, is to engage the community, because people do want to help with the type of work that we do. So where do we go next? So just what are our future directions? And I was going to say that this is one of the first non-COVID related talks that I've been involved in the last couple of months. And I was going to try and make it through the whole talk without mentioning the word COVID, but COVID has definitely made us think about how we're going to run our program. And how that we might see changes from it. So, you know, we've always loved going to our sites. We really feel that this builds relationships with our referral centers, and it does allow us to help them, as I mentioned before, navigate their space, and we can help them identify latent safety threats, and we're there to sort of point things out. It does show that we're also invested in our rural partners, because we do work with them in terms of referrals and transportation on a day-to-day basis. But with COVID, we have seen how quickly people are able to adapt to Zoom and online communication. And so we've just started to ask ourselves, if travel restrictions remain, is this something we could consider? And there is a small body of literature on telesimulation or virtual simulation that exists, and it can be acceptable from a participant satisfaction. So I'm not saying for sure that we're embarking on this, but it's definitely one of the summer projects that Jenny and I are going to think about and discuss. The Impacts Collaborative group that we work with has approached us about participating in a virtual education program this summer on status epilepticus, and the details are still being worked out, but whether or not some form of virtual education would be a benefit or an added plus to our program is something we're considering. And the last thing I'm embarrassed to say is that despite us working on this program for about 12 years, we still don't have a specific mobile education outreach website or a communication tool. With the fact that we haven't been going to our sites for the last couple of months, we've been opening up the lines of communication even more than usual and sharing resources. And so Jenny and I this summer are going to try and work on an information SharePoint so that our sites just have more ready access to us and some of the things that we can share with them. So before I go through the thank yous, I just wanted to say that, you know, we talk a lot about you know, our program and the ins and outs of it. And obviously Jenny and I really believe in mobile education and empowering the doctors and nurses that do most of the pediatric care in the province and in the country. But there's no bigger reward than when we get to a site and they tell us a story like, remember last year when you came for the, you know, the beta blocker overdose? Well, guess what? 2 weeks later, we actually had a child with that. And it was so helpful to go through the steps and the motions. Or we had one time where we did a coarctation case of the aorta, and we realized that a site didn't know how to find alprostadil or Prostin in their medication cart. And just us showing them then made a direct impact, because a couple of months later, they actually had a child with coarctation of the aorta. So those are the stories that you hear when you do outreach, and those are the stories that really keep us going. So I just wanted to thank a few people, because Jenny and I got to talk to the program about our program today, but it's definitely not all ours, and we were not the ones to build it from the ground up. So I'd like to thank Dr. Vincent Grant, who is our leader at KidSIM, the medical director of KidSIM, and he was one of the people that was instrumental in getting the mobile outreach program going. Obviously, Alberta Children's Hospital Foundation has given us a ton of support along the way. And then the teams that work with us, our trauma program provides us with educators and works closely with our case development. Our KidSIM core team is what keeps us organized, and our mannequins working, and our our beautiful drawers in the van stocked. The transport team collaborates with us on multiple initiatives, as well as the telemedicine group. And so really we wouldn't be here without all of the other people. Finally, I wanted to make a plug for Trek. They have also been super instrumental in providing us with resources to pass out to the communities when we visit them. So that's all the program that we had scheduled for today, and I guess I'll pass it over to Paula for questions.
I don't think Paula's mic is, she might be muted, or it might have gotten disconnected somehow. I'll just give Paula 1 second to see if it's a mute unmute issue. I don't think so. So we will maybe get Paula to dial in by phone. Apologies for the sort of technical.
Can you hear me now?
Oh, yeah, now we can hear you.
Okay, perfect. Sorry about that. So there was a question just before you entered into the COVID discussion that I think you've answered about experience with virtual outreach. There's another few questions around, do you have samples of a variety of different things to share, like policies, job descriptions, needs assessment, introductory letters, funding submissions. Are you able to share those with interested folks?
Yeah, can you hear me, Paula? Yep, absolutely. We collaborated with a bunch of different mobile education programs across the country who have been interested in our cases, or like I said, examples of the introductory letters or sign-up sheets. And so I don't know if our emails were included on the Spark webinar information, but if you contact either Jenny Chatfield or myself, we'll be happy to collaborate with you.
Great, thank you. Are your services open? Do you invite folks from local home and respite care providers, some of whom are working with kids with medical complexity and other issues in the home? Do you ever invite those folks to be part of the simulation training?
Jenny, do you want to touch just on family-centered care, or?
Sure, I can talk about that. So no, we haven't invited them in the past. We do have a program that does specific teaching for families. So it's individualized, it's tailored teaching specifically for the families. So for example, if a family is going to be going home with a trach, the families will come into our simulation session, into our simulation center, and they will have one-on-one teaching. So a facilitator and the parents or whoever makes up the family will come in and get teaching on how to manage a trach while you're at home with your child. Same thing goes for like seizure patients as well.
So if they have a specific caregiver that's involved with a chronic child or whatever, then that caregiver could be brought in. But like Jenny said, we haven't specifically invited the groups to our emergency department sessions at the hospitals, just because we feel that really is a team-based training with the equipment that's there. But it's a great idea and another way to do outreach education.
Great, thanks. And another question around, have you ever incorporated pediatric pain management, effective pediatric pain management in your simulations?
Absolutely. So we've worked on a couple of things in terms of pain. Almost always our trauma scenarios, when we run them, involve a child in pain, and one of the key teaching points is how to manage or treat pain. But a couple of years back, when we were doing the pain initiative in the province of Alberta, we actually did, as part of the first hour, a talk on pain, and we brought out a pain and a comfort kit to show the comfort measures as well as medication dosing and things like that. So currently we've been working it into the scenarios, but a couple of years back we actually spent about 30 minutes of the first hour time talking about pain.
Great. Are you aware of other similar simulation programs in other jurisdictions, provinces, and territories across the country?
There are some ones, and there's a lot of initiatives starting. There's some initiatives in BC. I know there's some initiatives in Hamilton. Some of our colleagues are doing some work in Hamilton. I don't know of one that's sort of as extensive so far as ours, but definitely there's sparks out there.
Oh, great. And do you provide consultation services to jurisdictions that might be interested in doing something provincially? outside of Alberta, I assume?
Yeah, that's a really great question. We have talked about it, and it has been on the table, and we've had conversations about it. So definitely, we are open to having conversations as to what that might look like. Yeah, what are your thoughts, Kerri?
Yeah, I think as by nature, the simulation community as well as the mobile outreach community has been a collaborative, and so we are happy to collaborate with anybody who's looking for information or to sort of get them going. And so I would just encourage you to reach out to us and contact us.
Great. You talked about barriers and challenges. What are some of the facilitators, the things that if they're in place make your job a lot easier or make the environment more conducive to uptake of what you've been teaching?
Well, I don't I know for me, I think being organized, so timely organization and clear communication seems to be one of the most important things in terms of getting people participating, coming out to see us. Anything left to the last minute doesn't we end up with a scramble. So I think clear communication with the sites is one of the most important things. Anything else, Jenny?
Yeah, definitely. We talked about facilitators being flexible and willing to go with the flow as things kind of happen, because we know life happens and we know that things are changing at the site all the time. So just having a facilitator who is very flexible and able to problem solve on the site or to access resources when they're out there to help problem solve as they go along is really helpful.
Wonderful. Thank you so much. That's all the questions so far. I'm just going to give folks a chance to enter any last minute questions they may have into the question box. And I want to definitely thank you both for your time today. I don't see any other questions coming in, so we do you folks have any last minute things you wanted to share? And if not, we'll close off the session.
No, I think we're good on our end.
Great, thank you so much. So thank you, Kerri and Jenny. Thank you for your all in attendance for your interest in this webinar today, despite all of our Zoom fatigue as a result of social distancing. Typically, Children's Healthcare Canada hosts our Spark Live webinars every Wednesday at 11 Eastern. However, during the COVID pandemic, we're offering some special editions of our knowledge sharing opportunities, which may fall outside our typical webinar slots. To stay up to date on all of our activities and events, please sign up for our Children's Healthcare Canada Spark newsletter if you haven't already done so, or you can follow us at Child Health Can on Twitter. It's always great if you can watch live, as the questions and comments enrich the discussions and learnings. But if you can't watch live, these sessions are all recorded and made available after the fact on our Knowledge Exchange network. Tomorrow, on Thursday, June 11th at 11 Eastern, we'll host another special COVID edition of Spark Live called Partnering During a Pandemic, featuring colleagues from another Children's Healthcare Canada member, the Children's Hospital of Eastern Ontario, or CHEO, and it's regarding their family partnership and engagement efforts during COVID-19. So thanks again for joining us today. Thanks to Children's Healthcare Canada member Alberta Children's Hospital for supporting our webinar program, and hopefully we'll see many of you back here tomorrow. Bye-bye, everyone.